Okay, so I believe we are going live.
And then I'll let you know when we're up on Facebook Live. It'll take me just a second.
Can you hear her when she talks from over there?
Yes, I can.
Wow,
Yeah.
it's a good microphone. Geez, look at my hair. It's crazy.
You always say that the higher the hair, the God.
Did
Yeah,
you?
almost look like my hair.
Oh. You know, yesterday I had a patient who wanted Bioclear. She's very wealthy. It was it was a very expensive case, very nice, but she had 2 old crowns on her lateral incisors. And you guys do crazy crowns, Bioclear crowns. I'm lazy. But she really wanted to get these Bioclear crowns. I had to take 2 crowns off and do Bioclear crowns. And it's not that hard to do, actually. It's just always about finding, it's like climbing a mountain. You just have to get a foothold here, and then you climb up here, and then you climb here, and then all of a sudden it's just a normal black triangle. They were beautiful. I just did a root overlay on the lingual, a root overlay on the facial, pat cord, pulled the cord out. It's like deep margin acquisition. The matrices were perfect. I did delayed wedging. It's like, wow. It's not as hard as you think to do a Bioclear crown on an anterior. I mean, this thing was prepped. This thing was prepped.
How long did it take?
How long did it take? An hour.
Oh,
Yeah, it's quite good, yeah.
Yeah, but I charge my aesthetic crown fee, and my aesthetic crown fee is 50% more than my crown fee. And you know, they want it, I'll do it.
so then a crown replacement would be mostly into dentine, right?
What's that?
You will have a lot of dentine and very less of enamel remaining when you replace a crown.
Right, but when you shrink wrap dentin, it's better than a crown. It is better than a crown. It's incredible. If we're going to do some studies on loading a tooth that's been injection overmolded with a full crown versus something that's like a bonded crown, and put it in a finite and put it into a shoeing machine and do cyclic fatigue, it'll probably outlast a crown, because you're not going to have any stress risers and stress corrosion at the margin, because you have a better blending of forces, like gold. Bioclear's like gold. Bioclear blends the forces across the tooth in a longer surface. So we're going to do research on that to show that a Bioclear crown will outlast a zirconia crown or a porcelain crown. Not a gold crown, though. Gold crown would be probably the same. What do you think, Allie? Does that make sense?
Yeah, but the gold crown will be a little bit like higher for the conservative preparation, just a little bit.
Yeah,
and it's cool.
I think you're live on Facebook, Carisha?
Correct. You're live on Facebook.
We're live on Facebook. Very good.
Okay, we are. So everyone, welcome again to this webinar Wednesday by Bioclear. So we are up here with the second webinar of the series. Today we will be dealing with extreme Bioclear cases, injection overmolding, and smile design for worn teeth and collapsed dentitions. Along with this, we will have a live demo by Dr. Clark on treating these cases and the finishing and polishing protocol that we guys follow. So without further ado, let's move to Dr. Clark's presentation here.
All right. Good morning, everyone. Good morning. Well, it's good evening over there. So I want to say hello to our 2 other panelists. We have Dr. Abdurrahman, who will be heading up the 4th Learning Center in Cairo. Can you say good evening to Ali? Ali?
Good evening,
Good
Dr.
evening,
Ali.
everyone.
Good evening, Ali.
Thank you.
And Dr. Jane.
Yeah,
Hello, Dr.
you know what? One of the first Bioclear restorations ever done in India is in his mouth.
Very
He was
good.
my first live patient.
Don't they feel great? They feel so good. Patients will look at a restoration for about 2 months, and then they quit looking at it, but they feel it every day.
So we have a long-term follow-up right there.
There you go.
Yeah.
All right. So we're excited to get back to the presentation. We had we were not able to get through everything last time, so we're going to finish up what we didn't get done last time. And so we're going to jump right in, and we're going to talk about how to begin to leverage the Bioclear method to do bigger, more complicated cases. Everything has to start with one tooth, and then 2 teeth, and then 25 teeth. And so there's a huge difference between injection molding and injection overmolding and bonding, okay? So here's an example of bonding. And when you take cold composite and try to push it in between the teeth, it just doesn't work. And I've been using a microscope for 30 years. That's how old I am. I was one of the first people in the world to use a microscope because I'm crazy, okay? I'm crazy. And so when you work under the microscope, you see things that change your world. And using a microscope changed my world. And so when I built the Bioclear Matrix, I looked under the microscope and I said, this is going to be amazing. This is going to be amazing. So let's go over the 5 foundational pillars of the Bioclear method. And number 1 is we have to use disclosing solution, and then we have to blast away both the protein pellicle and the biofilm. Now you can remove it with a burr, but that's not a very safe way to remove biofilm in interproximal areas. It can be very damaging. So we really want to disclose and blast. And then we want to have modern cavity preparations. And so we need to put these teeth into compression and let the composite shrink around the tooth. And so the cavity preparation has to allow for that. The next thing are the matrices. These are not just matrices. These are anatomic tooth forms that allow the matrix to sit away from the tooth. Now, next week and the week after, we're going to talk about the class 2, how the composite goes around the tooth rather than in the tooth. The composite goes around the tooth for a class 2. And people are more used to that for an anterior, but in a class 2, it's the same thing. And then everything gets fixed. The C factor, we don't have to worry so much about dent and bonding, but we need to be able to have a clear anatomic tooth form to allow the light through to go around the tooth, okay? Next thing is injection molding. We heat the composite, we heat the flowable, we heat the paste, and we use adhesive as a surfactant before the flowable. So 1, 2, 3. And so that's the only way that we're able to get the composite to integrate to an infinity edge and really transform the tooth. The last thing is the Rockstar polish. So today we're going to show the Rockstar polish, how that system works. And we'll do a live demonstration now that we've got the camera all figured out for that. We encourage you to ask questions. Well, we can answer a few questions. And Carissa, where do we want those questions?
They will be putting questions in the Facebook chat.
So in the Facebook chat, you can ask questions. And then if we can have our panelists, Abdul Rahman, Pratik, and it's Jane, right? Is it Jane? Am I saying that right?
Yes, Dr. Jane.
Okay. They can answer some of the simple questions, and maybe you can pass some of those questions to me to answer as we go along. And so I want to start with this case. Did we show this case last time? The wife of the orthodontist?
No, we didn't.
Okay. So this is the wife of an orthodontist who found me on the internet. Now, we have a lot of patients going to the internet to learn about dentistry, don't we? And do you know the #1 country looking at Bioclear? Can you guess, Pratik? The #1 company that's looking at Bioclear videos, what country is that?
India.
India. And those are patients, okay? Those are patients looking at Bioclear. I get questions all the time. This patient went on the internet looking for Bioclear, so I want to tell her story. She is the wife of an orthodontist, okay? Her husband does only orthodontics. In the United States, people just kind of do one thing. Her husband only does ortho. And when he finished her case, he sent his wife to a local dentist who does not do Bioclear, and he did bonding, okay? So this is the wife of the orthodontist, and she went for bonding on the lateral incisor. Okay, so I want everyone to take a look at that lateral incisor. The dentist did bonding on the lateral incisor, and then when he got done, he handed the mirror to the patient, and the patient said, "Oh, this is terrible. I don't like it." And the dentist was shocked because he said, "Hey, the orthodontist says do some bonding on the lateral." I did some bonding on the lateral, and she said, "I don't like it." So remember, I'm the next guy. She already went and had this bonding done a couple months before and then came to find me. So she's telling me this story. I don't like the lateral incisor that this guy did. And I was kind of shaking my head, and I said, "Well, tell me what you don't like." And she said, "It's the wrong blank." What do you think she said about this lateral incisor? It's the wrong blank. Let's see what the people watching on Facebook Live, what word did she use? It's the wrong blank. There's a lot of words that she could have used. And you can look in your eye and say, "Well, I think it's the wrong blank." But I want you to tell me what you think she said about the peg lateral that was treated with this bonding. You can obviously see where the bonding was added on the mesial. The orthodontist told the dentist, "I want you to close the space on the mesial of the 2-2. I want you to put bonding and close the space." And so the orthodontist was happy, the dentist was happy, but the lady, the wife of the orthodontist, was mad. It's the wrong blank. What is it? What's the word? There's a delay. So how long do we have to wait, do you think? About 30 seconds. Do we have anybody's answers? It's very interesting to talk about patient preferences and a patient-centered outcome. Allie's got a great presentation about using doctors, using the patient eyes to look at things. Maybe you can have Allie come back and show that presentation another time. I think it's a great presentation about using your patient eyes to look at things. We have a bias as doctors.
Wrong shape is the reply.
Perfect. I can see that you've had your evening tea, okay? You're thinking, it's the wrong shape. You know what a lot of doctors say? I'm going to let our panelists guess here. What do a lot of doctors say instead of shape? What do you think the doctors say?
Ratios.
Ratios, yeah, but that's not what patients think. What else do doctors say? It's the wrong
Golden,
what?
golden proportion.
Yeah, and they say that. What else? Come on, think. What are dentists always afraid of? What are we afraid of sometimes?
Black triangles.
Black triangles.
Black triangles? Yep. That's not, wasn't it though? A lot of dentists.
I think the dentists were not afraid of the black triangle.
No, they're not thinking about it. No. What are the dentists afraid of? Nobody's thinking. Come on. What's the thing that dentists always say? Oh, it's the wrong blank. And no, it's not what patients see. Come on.
Yeah, it's the color, like he needs the match, the color.
Yes. Dentists often say it's the wrong color. Now, it isn't the right color, but it's never the right color. Composite never really matches the tooth. The goal with Bioclear is to have it blend with an infinity edge. So we'll show you how to blend the composite so it'll blend in, because it never matches. The tooth has 5 different colors, and we don't layer anymore. Layering is dead, basically. Layering is almost gone in the world. When you take a look at the whole world together, there are areas that still do layering, which is okay, but patients don't really care, and it's weaker, it takes longer, and so layering is pretty much disappearing. So we need to teach you how to blend it in so it looks like a more consistent color. But that's a good comment. Yep, she didn't complain about the color. So let me ask our panelists, and then we can ask people on Facebook Live. One of the problems with this shape of the tooth is that it's too wide. It's too wide mesiodistally. Now, the patient doesn't know that the lateral incisor is supposed to be smaller than the central incisor when you view it from the facial. They have a feeling that something's wrong. So when she says it's the wrong shape, what is she saying? She says it's the wrong width mesiodistally, but it's also a weird shape. It blends from wide to narrow, and it looks like a triangle. That's wrong. So we have to change the emergence profile. We have to change the emergence profile. So where do you want to change the emergence profile? Do you want to change the emergence profile supragingivally, like this doctor did with this bonding? Do you want to change the emergence profile equigingivally and make kind of a shelf there? Or do you want to change the emergence profile subgingivally, a couple of 1 to 2 millimeters subgingivally? Where do you want to change the emergence profile? So let's ask all of our people on Facebook Live optimally to change the shape of this tooth. Should we change the shape supragingival up here, equigingival, or subgingival? Let's just go ahead and listen to the answers. It'll take about 30 seconds for you to get a chance to answer that question. You know, it's always interesting to treat dentists or to treat the wife or husband of dentists. And I know our panelists treat a lot of dentists, a lot of dentist wives and husbands. So I think it's always kind of fun. I think it's always interesting. Normally, dentists are pretty good patients most of the time, right? Would you agree, Ali?
They don't. They might be asking too many questions, but they know the process and they pay. That's the most important part.
They pay.
They don't talk about. Yeah.
So the answers coming in are mostly subgingival.
Right.
Shape subgingivally with function.
We want to change the emergence profile subgingivally. So let me ask you something. How do you change the emergence profile subgingivally without Bioclear? It's almost impossible. So one of the miracles of Bioclear is to be able to push the soft tissue subgingivally. The matrix is stronger than the soft tissue, especially with the new HD material. It pushes the gums away and gets a perfect seal. That's a miracle. And that's still amazing to me today, 20 years after, 15 years after inventing Bioclear, is to look under the microscope and say, wow, look at that fit. And I'm 2 millimeters subgingival. It's a miracle, right? And so here's the thing to keep in mind. I think we'd all like to do these beautiful cases and transform people's lives and change their face, change the whole face. But the dentist who did the bonding, who doesn't know about Bioclear, he did one tooth. He just charged a low fee for bonding. And now she's mad at this guy. She's mad at the dentist, and the dentist doesn't get to do the case. So when this patient came to me as the second dentist, and she said, I don't like this bonding. And I said, what about these black triangles? Do you like those? And she says, no, I hate them. She said, can you treat my black triangles? I said, yes. And she said, that's part of the reason that I'm here. I said, what? I said, what else? I said, do you like the fact that this tooth is tipped slightly? Now, she's had braces 3 times. She's had orthodontics 3 times. We're not doing orthodontics again. It's not going to happen. I said, would you like to get rid of your bonded lingual retainer? Because once I'm done with Bioclear, the teeth are so stable orthodontically that we don't need to do a bonded retainer. We can just do a removable retainer. And then I said, what about your incisal edge? Do you like the fact that your incisal edge is uneven? She says, no. Can you fix that? And I said, yes. Yes, I can. And so when I'm done with this case, we're going to talk a little bit about the smile design gauge now. I put her smile design gauge in here. And as you look at the case, you realize, man, there's a lot going on here. So I took the smile design gauge and I moved it over about 1/4 millimeter. And I looked at the case. I said, if I move her midline over 1/4 millimeter, that'll change everything by 1/2 millimeter, because 1/4 moving becomes 1/2 millimeter. And now I'm going to shift the midline over so I can even out the space. That allows me to add 1 millimeter on the distal of the 2-1. And if I can add 1 millimeter on the distal of the 2-1, that means like the 2-2 will not have to be such a wide shape. And now I can satisfy and create a smaller lateral incisor. So when I'm done with her case, that's the treatment plan. She's going to have 7 black triangles on the top, 5 black triangles on the bottom. We're going to cover the dark area here by doing a little bit of enamelplasty here. We're going to change the incisal edge here. I'm going to add to the poor negative space where she's so sharp. She doesn't like the sharp space. It's a very masculine space here. I'm going to do additive dentistry here. And by the time I get done, the cost of this treatment will be the same as buying a car. Not an expensive car, used car, okay? So the dentist who does the bonding, he gets to do a little one tooth and charge, $100, right? This is a $20,000 case. Now, 20 million rupees, I don't know, right? But where do you stop in a case like this? She doesn't want bonding. She wants to have a beautiful young smile. But the question is, do you have the confidence to change this woman's entire dentition? And so our goal with all of the teaching that our proctors are doing with the learning centers to give you the confidence, the skills to understand the matrix, to have the confidence to restore a tooth like this. Because I'll tell you what, it's going to be 20 teeth by the time we're done. And the neat thing, Abdul Rahman, Ali showed a case where the patient came in and did 1 or 2 teeth at a time. How many appointments did it take for you to treat that patient that came in for 1 or 2 teeth at a time? Didn't he come in for like 4 or 5 appointments, Abdul Rahman?
Yeah, almost 6 appointments.
Yeah. So nobody wants to do one crown at a time, right? Nobody wants to do a crown and then a crown and then a crown. That doesn't make sense. But with Bioclear, it's okay to do a couple teeth at a time. It's no big deal. So it allows us a lot more flexibility to reconstruct people's dentition with the Bioclear method. So what we're going to do here in this, for our first exercise, is we're going to go ahead and do a deep class 3. Once again, Bioclear Matrix is such a beautiful solution for a tooth like this. We know that putting a crown on this tooth is going to remove the cingulum. If you do a traditional crown here, you remove the cingulum. And if I remove the cingulum for a crown, the tooth is much weaker. It can break much more readily. So the cingulum is the heart and the soul of the incisor tooth. We don't want to cut through the cingulum. All right, so we're going to use an A102. Sometimes we do what's called deep margin acquisition, where we pack cord, but then you take the cord out before the matrix is placed. This is an old photograph. And then we're going to combine it with, this is the A102 matrix we're going to use here, and we're going to combine that with the new black triangle matrices. Now, Pratik, have you tried the new black triangle matrices with the color coding?
Yes. Yeah.
We love those things. I'm now using those as a 360 veneer matrix because they just fit really nicely with the HD. So I'm using them sometimes, especially for lower incisors, to do a 360 veneer.
For me, they fit too close in the incisal area.
What's that?
They fit too tight in the incisal area.
Oh,
Because
so
incisal has enough space.
You would like more curvature in the incisal.
Yes.
Right.
Something
so
like a 360.
What's that?
Something like a 360 matrix.
Right. So this is the good thing. Pratik loves the 360. We have other doctors that just love the black triangle matrix. I don't know, Ali, what are your favorite matrices? Abdurrahman.
Yeah, for me, I like the traditional one, but the HD, not the color coding is, I used to trim the matrix. I used to like to do some modification.
So Ali, yeah, Ali likes to trim and use matrices. Other people are lazy. So we want everyone to use the matrices and then find the matrices that you love. So Pratik loves the 360 veneer, and Abdurrahman loves original Bioclear, the A102, A103. And Jane, how much Bioclear are you doing now?
I guess my prosthetics, indirect prosthetics have gone down.
What's that?
But my indirect prosthetics have gone down since I started doing Bioclear.
Yeah. So what's your favorite matrices for the anterior?
My favorites would be, I would go with the traditional one. Like Dr. Ali, I go with the traditional ones.
Yep. Okay. So we want to give everybody a chance. So today I'm going to do an exercise and use both matrices. Then you'll see the advantages and disadvantages of both. And then each doctor, I'm always very interested. Everybody's a little bit different. So we're going to use two systems together here. So let's go ahead and start with the exercise. And then if people have questions, let's, Pratik, if you can look at the
Yes.
Facebook Live for questions.
One eye on the Facebook Live.
What's that?
One eye is on the Facebook Live.
Okay, good. Okay, I'm going to switch now to the live microscope feed. So you panelists have to
Stop our video.
turn your video off. What's that? Do a stop share. I'll have to do stop share, okay. All right. Now what do I do? Are we good? All right, I hope everyone can see me. And so what we're going to be doing is we're going to be doing a combined exercise with the A102 matrix on the distal of the 1-1, and then the black triangle matrix here. So this is the black triangle gauge. And so we're going to gauge the black triangle here. And this looks like about a blue on the facial, but if you gauge it from the lingual, it's more like a green. So we'll go ahead and try the matrices in beforehand just to see. And then I'm going to use, this is the new Bioclear kit by Common. It's a really wonderful little burr kit. I'm going to be using the burr number 3 from the burr kit. We have to do what's called a radius bevel. And so the radius bevel should be the same width as the deficient tooth structure. So that's about a 3 millimeter defect. So my radius bevel is going to be about here, and that is going to allow beautiful blending of the composite. And then we don't have to worry about getting a perfect match. So when we're cutting the radius bevel, another burr that we can use is the burr number 1 or burr number 2 in the burr kit. We call this the Hershey's Kiss. Do they have Hershey's Kiss? The chocolate Hershey's Kiss in India? Do they have it in Egypt? Does anybody know what that is?
Yes, it's available in India.
Okay, so this is the Hershey's Kiss burr. How about in Egypt, Ali? So can everyone see the video okay?
Yep.
Yes.
So one of the reasons that we use this burr for teaching, and we use this burr at the dental schools, it allows us to show them the proper shape of a radius bevel. A radius bevel needs to be convex. And the burr, most burrs cut a concave radius bevel. And so that's the idea. And then I'll go ahead and, some of you may not have that burr. And so the burr number 3 is our workhorse burr that we'll use later. And that burr has to be used more actively. You've got to roll it so that it becomes tangential both to the outside and the inside. And so we want a gradual transition from thick to thin, a gradual transition so that you don't see the composite. So that is the radius bevel, and it allows for beautiful blending. Now, we normally do not cut the burr to remove biofilm, but I'm not setting up my blaster here today. So I'm just going to remove the glaze from the tooth. Normally we would only use a blaster for this, but I'm using this because the plastic tooth, I have to cut the glaze off the plastic tooth. So this area we would just use blasting. So now we're ready to go. I'm going to go ahead. I've got to make sure that the contacts are appropriate. So I'm going to be using the little sanders that come with the kit. These are critical. We want to use these sanders before we put the rubber dam on. So I'm going to go ahead and use the True Contact Sanders. We're going to start with the blue and then go to the orange and then to the red. And then we're going to be using the A102 matrix. And like Ali says, he likes the HD. So we have A101, 102, 103, 104, and 105. Today I'm going to be using the A102 HD matrix for the distal. And the traditional Bioclear has a little tab on the incisal. You can see the little tab right there. So I'll hold that aside. And then for the black triangle matrices, we have large and small, and then 4 colors in each. So there's a large and a small. I'll be using the large matrix. Now I'm going to be using the blue. The blue have the most curvature. The green corresponds to the green or diastema closure in the classic, and the pink corresponds to the pink like the A102 in classic Bioclear. So in classic Bioclear, we have 2 curvatures, and then you have to modify the green if you want it to look more like a yellow. So that's kind of how the color coding goes. You have a poster for me?
So a question here is, do you have to give a bevel on the palatal side also?
The bevel on the palatal side, thank you for asking. The bevel on the palatal side is just a normal bevel. It's just a small bevel. It's not a structural bevel or an aesthetic bevel, so it's just a very small bevel just to decrease the C factor and to get a good adhesion. So before the rubber dam goes on, my dental assistant goes in and grooms all the contacts so that the rubber dam doesn't tear. And then I go to the orange sander because I'm going to restore the mesial and distal of the 1-1. And I'm not going to be doing it today for the demonstration, but we would be normally restoring these 2 teeth together. And then at the midline, sometimes I'll use the red sander. That allows the matrix to be seated. The #1 problem with Bioclear is people don't adjust the contacts. You have to optimize the contact or the matrix doesn't slide in. So let's go ahead and try in our matrices. So I'm going to be using the large, and we'll grab a couple of the blues. And make sure they're not nesting together. I got a couple here. So this is actually something that you need to do with every Bioclear matrix that has a lot of curvature. The matrix has to be rotated in at an angle like that because of the curvature. If you try and insert the matrix straight, sometimes it'll catch and it'll ruin the matrix. So I'll bring it in like that. And so we're going to be restoring the 1-1. And so this matrix over here is called my shield matrix. And then I'm going to be, I'll put that in there while I'm injection molding the 1-1. So the 2-1 has a shield matrix, and that shield matrix has several purposes. And so I'm going to slide the A102. Once again, the Bioclear matrix, the only way to seal the gingival margin is you have to drive the matrix all the way to the attachment. And we don't see biologic width violation with Bioclear because of the fit, but you will have a problem with soft tissue health if the matrix isn't seated. So the #1 problem is people have their matrix up here. That's not going to work. The matrix has to go all the way to the attachment. And we see incredible soft tissue response here. So we're ready to injection mold #8. And if we've got some phosphoric acid, that would be a great thing to show them because I don't want anyone to be confused, Carissa. So if we can grab some phosphoric on #8, that would be lovely. Now, do we have to have Tanya here for the live demo?
Yeah, Tanya.
Okay, so I'm going to go ahead and ask everybody what they think the purpose is of the shield matrix we're going to be restoring normally, let's say we were just doing the 2 front teeth. What would be the purpose of the shield matrix if I'm going to restore the 2-1 later? So I'm going to do this now. And as soon as this tooth is done, then we do the left central incisor. So what's the purpose of the shield matrix? Let's go ahead and open up the microphones for Pratik and see if yeah, I think so. What the purpose of the shield matrix is.
Answer that or wait for the people to answer?
Let's wait for the people to answer. Thank you, Pratik. I'm going to go ahead and etch this tooth while I'm waiting an answer for what the purpose of the shield matrix is. We're going to do a total etch. Selective etching is old. We don't talk about selective etching anymore. That's something that we don't do anymore. We're going to be using Scotch Bond Universal, which is perfect for using for a total etch. So we no longer do self-etching.
The reply here is to hold the shape of the adjacent tooth.
Perfect. That's number 1. So what would be number 2? Let's have the high-speed section.
To give proper shape to the 1-1 or the number.
Is my mic up? Now this will sometimes happen. It's always important to make sure that your matrix is in the appropriate position. Sometimes you've got to put it back in. And I think people are surprised that we very rarely get any bleeding with Bioclear because the matrix does such a good job of putting pressure. But if I have bleeding, I'll simply put some astringent on the outside of the matrix, a ferric sulfate on the outside of the matrix while I'm doing the procedure. That will stop the bleeding. So this is what we call the aquarium matrix, to wrap the tooth. And then there was one other purpose to the shield matrix. And I have
to prevent over contouring of the tooth that we are working on.
Say that, what's that again, Pratik?
A reply here is that to prevent over contouring of the tooth that we are working on.
Yep, and then there's one more thing. The other thing, which is very important when you're doing a big case, it keeps all of the adhesive and the composite off of the tooth while you're injection molding, because when you injection mold, adhesive and flowable can go away on the other teeth, and we don't want adhesive on this tooth yet. So that it protects the other tooth just logistically and makes your life better as an operator to do that. All right, so we have freshly cut dentin tubules on the distal of the 2-1 or the 1-1. So now I'm going to go ahead and we're going to massage the Scotch Bond Universal into dentin tubules for a full 20 seconds. And we have the medium scrubby, which is the yellow one. So we're going to massage the Scotch Bond Universal into the freshly cut dentin tubules. Now, if I'm doing a peg lateral or a black triangle, that's not so important. But if I'm doing, then go ahead and contra angle those about 45 like that. So I'm going to go ahead and massage the Scotch Bond Universal for a full 20 seconds into dentin tubules. And how do I know it's been 20 seconds? It's happy birthday to you, cumpleaños feliz. It's happy birthday twice. 20 seconds is a long time. And then we're going to go ahead and air thin. And then we're going to light cure. Always make sure your matrices are seated. So curing light, please. And then we're going to get that paddle if you've got it.
Yes.
So I'm going to cure that for 10 seconds. And now we're ready for injection molding. So injection molding involves 3 different resins. So let's let some of our panelists tell us, okay, now we're ready to injection mold this tooth, and we're going to do one shot. There's no delayed wedging. There's no layering. We're going to injection mold this tooth. What are the 3 steps of injection molding as far as resins? So let's hear it from the panelists. I'm about to injection mold. What's step 1? What's number 2? And what's number 3? We're all ready to go. So
heat the composite.
What's that?
Heat up the composite.
We heat up the composite, okay? But what goes in first? What goes in first?
Bonding. The bonding agent.
The adhesive
Surfactant.
goes in as a surfactant. Do we light cure that?
Nope.
No.
No. We air thin that. Then what's
Yeah.
number 2?
Heated
Then,
flow.
Heated flow. We're going to inject very purposely. There's a very definitive method, and that's why we teach hands-on classes, because we have to displace the surfactant with the heated flowable. And then what's the third thing that we do?
Heated
inject
paste.
the composite
Heated
composite.
paste. All right. So let's go ahead and do it. All right. So I'm going to go ahead and reapply adhesive, but this time as a surfactant. So let me have a big scrubby. Good morning, Tommy. So you want to use a lot of adhesive here, and I think this is what shocks people is you're going to use a whole bunch of adhesive, probably 10 times more than you think you need. Adhesive, please. Now, sometimes people say, "Oh, you're using a lot of composite or this or that." Remember the lady that came to see me? She's going to spend the price of a used automobile to do Bioclear. Once your patients have value, once you have value for this procedure, it's better than a crown, frankly. And so you should be charging a crown fee for this procedure. And when you charge a crown fee, then you won't worry about using a little bit more composite than you did in the old days when you did bonding. Okay, this is not bonding. So we're going to use enough composite so that this procedure can last for 20 years, maybe more. Did you hear what I said? This should last for 20 years. So that's number 1 was the adhesive. Now we're going to take heated flowable. We're going to inject starting at the palatal, and we're going to push the adhesive out of the way. We always inject into the matrix tooth interface, and then we always inject through the contact. That's why these create beautiful, stable orthodontic contacts. And then we inject 45 degrees, pushing the surfactant out of the restoration, and then we coat the contact, and then we'll come around. And don't you wish you could just take your patient's head and spin it like that? And now we're going to inject into the flowable that went around the corner, displacing the adhesive, and then we always fill the lingual. We always fill the lingual with flowable so that we have good back pressure, thixotropic pressure when we injection mold. And then we bring in the heated paste. I always want to start on the gingival. My compial is about 1/2 millimeter off the tooth. We don't want to touch the tooth because that will create turbulence or uneven injection molding. We bring this back and forth. I'll push in the whole compial, and then we bring in our paddle. I'm going to show you how much that this matrix is distended from that matrix. That's going to alter the form. So you've got to massage the matrix until it matches your shield matrix. Can you see how I'm matching that now? We just massage it like that. And then we can get just rid of a little bit of the composite along the gum line. I'm going to leave the rest so I don't disturb my injection molding. Have a dry brush, please. Now today, my matrix has pretty good containment of the composite, but normally there's a chance that your composite will go out and be on the wrong side. So I'll use several dry brushes to blot away the excess. And I'll do the same here and here. And then we'll go ahead and light cure. Okay. So we need to make sure that these are fully light cured. So I'll come in and I'll do paddle, please. 10 seconds and then 10 seconds. Okay, come away now. So I just brought the orange paddle in there because it's important to use the orange paddle. Now I'm looking at the television monitor, so it's not hurting my eyes, but I'm not looking directly at the light. That's very bad for your eyes. So then we do 10 seconds on each area, and then I'll do 10 seconds on the gingival, lingual, and 10 seconds on the incisal gingival. So I'm gonna just hurry that up, even though I'm not really done light curing. And now we're gonna go ahead and disassemble the matrices, we take our shield matrix off and put it aside for later. And then we're going to take the Explorer and remove the matrix. Like so. Now the HD matrix, like Ali was saying, is a lot stronger than traditional. So we tend to use more and more of the HD version of the matrix whenever we're doing a black triangle or a 360 veneer. The HD is about 3 times as strong. We'll talk about the HD next week for the posterior. And that is a monolithic restoration. And we know that monolithic Filtech has the same compressive strength as Emax Press. And people trust Emax Press. So that composite, when it's monolithic and injection molded, has the same compressive strength as Emax Press. And these things can last a very long time. So I'm going to show the sculpting of this. But before we do that, let's see what questions people might have from Facebook Live, Pratik. And then I'm not sure that Abdurrahman is still with us. So for Jane or for Pratik or Ali, let's wait and get some questions from Facebook Live. And then if we don't see any questions, Pratik, you can kind of, and Jane, you can tell me the kind of questions that you typically have to answer for your students in your courses.
Okay, so one of the common questions that is asked to me is, you believe in total etch. Why not selective etch? And what about the sensitivity that comes along?
That's a question.
I can answer this question to David if I can do that, because for total etch, if I can answer, just let me know and I will reply for this question. Total etch, selective etch.
Go ahead, Ali.
Okay, so when someone asks me why you're not doing selective etch, I will ask him another question so he can understand why I don't do that kind of etching anymore. So I ask him, are you sure 100% that when you do select the enamel for etch and rinse procedures, that your etching will not touch a part of the dentin? He says, no, I'm not sure. So there is nothing called selective etch. You cannot select only the enamel unless you have only enamel.
No, you know who invented selective etch? A chemist, not a dentist. And here's the other thing. I'm using a microscope. And when you look under the microscope, you realize there's no way. It's impossible to do selective etching. There are areas that you will not etch. You will miss some enamel. You will not etch enamel if you're trying to do selective etching. I can guarantee you that. And so
the only way to do that is to do the adhesive first for everything and refresh the enamel surface and do etch the enamel surface. So it's like 2 days working.
Okay, so in American sports, we do this. This is timeout. Okay, we're going to have a timeout. This is the real answer to that. With composite and the Bioclear method, we have a new world. It works. The biggest composite company in the world, 3M, advocates for every single step of the Bioclear method. It's all been researched, and we will give you the links for the research. Selective etching and some of these other conversations are old conversations from the old world. We have a brand new world, and the Bioclear method is a recipe. We all do it the same way. It's all been proven. So it's okay to answer those questions, but then say selective etching is an old conversation, okay? There are a lot of old conversations that kind of get in the way for injection molding. You have to answer them, but then say, okay, we're not going to talk about that ever again, okay? It's like an old-fashioned telephone that you dial up. That's interesting, but it's not relevant, okay? We don't use dial-up telephones anymore, okay? All right. So did we have any other questions about the injection molding?
Yes. Don't you think the labiolingual thickness of the tooth is too much after you injection mold?
We get that every time. That's a question that we get from beginners. And then the answer to that is, I'll let Pratik or Jane answer that question.
It takes 5 minutes to build it down.
Yeah. Yeah.
As we say in Bollywood language, picture abhi baki hai mere dost. It's not over yet. It's the work is still remaining.
Say that again.
It's still remain. The work is still remaining, as there is a famous dialogue in Bollywood movies that picture abhi baki hai mere dost means the movie is still on. It's not over yet.
Awesome. I like that. I'm going to need a little bit more explanation, but I think I understand, and I'm going to use that in my lectures, but you're going to have to give me the full story, but I like that. Yeah, the movie is still on.
I'll share that.
Okay.
I'll share that.
That's awesome. All right. So now we're going to go ahead and go to the cutback phase, and we're going to answer those questions. So I need some high-speed section here, please, Tom. So one of the things that happens with Bioclear is we injection overmold the tooth, and then we have to learn how to sculpt it in a very safe and efficient manner. This is another reason that taking these Bioclear courses is important, because you can learn from the experts. It can take you months and months and months to figure this out on your own, or you can just learn from an expert and you can start to do this tomorrow in your clinic. So we always cut 1 millimeter from the natural incisal edge, no more, no less, exactly 1 millimeter, and we always cut dry. Get my waters on. Okay.
We've lost the microscope feed.
Oh, we lost the microscope feed? Thank you. Thank you for keeping us on track here.
Yeah, back on.
Thank you. Thank you. Okay, here we go. 1 millimeter, no more, no less. And then we cut 1 millimeter, and I'm going to show you in this dimension how easy it is to do this.
So you always cut that dry?
Always. We'll answer, and I'll tell you why in a minute. Always dry. And that's it. Now we're going to go to the SoftFlex XT disc. Now, I'm not going to do the neighboring tooth today out of the interest of time, but we always take each tooth to 80%, 80%, before we move to the next tooth. Whenever we're doing a 2 teeth or a full mouth case, we don't want to lose our way. We don't want to lose our references and get confused later. So then we're going to take the SoftFlex XT disc. We're going to angle it at about 15 degrees to the palatal, not the facial, 15 degrees to the palatal, like this. And then we'll take the disc, and we love to use it in what we call the inverted position. We're going to start on the incisal third. And then we slow the disc down to go into the gingival half. There's less to remove there. And now I'll bring my bumpers in here. And then we bring the disc in at a 45 degrees because you have to roll the incisal third in. So we're going to bring that in like so. And I'll do the same thing on the lingual, 45 degrees. So even though it looks like it's only 1 millimeter thick, it's actually 2 millimeters thick once you drop below the incisal edge. So that incisal edge will not break. It's virtually indestructible because it is 2 millimeters wide. And then we bring the disc in. We're going to come in here. Now that the disc is worn out, I can come in and round the incisal embrasure. And then I can bring in the incisal embrasure here. The incisal embrasures, once you become good with the disc, are very easy. It's really something that most dentists don't know how to do, is to how to make an incisal edge proper with the disc. Incisal edges are very important to patients. They can see the incisal edges. And now, in 3 minutes, I'm done. The last thing I'll do before I move on is I'll take the Q finisher burr. We love this burr because it cuts and it polishes at the same time. And I'm going to make a lingual fossa here. I'll make a lingual fossa here in the middle of the tooth. Now you need to stay away from the incisal edge because that needs to be 2 millimeters thick. And we need to stay away from the cingulum because that's where the strength of the tooth is. So we're going to create a nice fossa here. And depending on the occlusion will be just like this little spot right here. Where's my pencil? Do I have a pencil? This little spot right here. You see the natural dentiform right there? Can you see that? That's what the occlusion would look like. You just take it back to the natural enamel and then we're done. So I'm going to come in and I'll create my little concavity on the lingual. And you can see it right there. That's the natural enamel right there. So let's say that if a patient, if this was their occlusion would be right here. And then as they go into protrusion, all of the protrusion can be on composite because it's going to be balanced here. So all of the protrusion can be on composite. So this would be here's protrusive marks here. And then eccentric stop would be on the native enamel. And it works perfect. So we're able to actually take people's occlusion and improve their occlusion. So that is the preparation for the final step for the Rockstar polish. And then what you have here is you have two zones. You have the Bioclear zone, which is this area here where the natural shine is still present. Everything here is Bioclear, and here is your injection zone here. And we're going to marry this injection zone. We're going to marry that to the Bioclear zone, which is here and here. That's natural. That's the mylar finish area, and this is where we just cut that away. And that should only take 2 minutes. Well, 3 minutes. So now we're ready for the Rockstar polish. So Pratik had a question about the cutback phase. So the first thing we did was we did injection molding. The next thing we do is we do the quick cutback, which we have to teach people. This is not a skill that anyone gets in dental school. We have to do it safely and quickly. So, so let's ask, I think Pratik had a question about when I do the cutback, do I do the cutback dry? Is that correct, Pratik?
Yes, that's a common question asked.
Yeah, and so let me answer that. Remember, the Bioclear method is an older method now. We've been doing it for almost over 10 years, I think 2000, yeah, for 13 years. So we cut dry because we can. When you cut dry, composite is an amazing insulator. It has very good, has very low thermal conductivity. So composite is an amazing insulator. If you cut dry on zirconia, if you cut dry on gold, you'll kill the pulp. But cutting dry with a quick motion and using a little air, the tooth doesn't feel any heat. The reason we cut dry is because it cuts 3 times faster. It creates a little bit of heat, which softens the composite, and you can cut right through. The other reason that we always cut dry is because if I find a white spot on the composite, that's where a bubble is. There was a void. We don't want to contaminate that void with water, because if we find a void after we do the cutback, it looks like a little white circle. We simply just put a little adhesive on that, air thin it, take a little heated flowable composite and tease it into the defect, and then disc it back. So there's 2 reasons we cut dry. Number 1, it's safer, it's more efficient, it cuts 3 times faster when it's dry. Number 2 is that we're able to leave a powder trail, and that powder shows us where we're cutting, where the Bioclear zone is, And then also if we have a void, we'll see a circle, and that allows us to do what's called augmentation, where we take some adhesive and flowable, put it right in that spot. We don't have to do anything to prepare the composite. It has plenty of methacrylate sites. We put the adhesive and flow on anytime we're going to augment. And now I never say the word repair because repair sounds cheap. So we augment any little white spots. Good. Questions? Pratik, Ali,
Yep.
Jane?
Yep.
Other questions?
Yes. Is this technique in any way less superior in terms of characterization and optical properties that can be achieved?
Answer that. Ask that question again.
Is this technique in any way less superior in terms of characterization and optical properties that can be achieved through layering?
It's actually better. When you layer, you're going to incorporate air bubbles. So I can show case after case after case of layered cases that within 2 years looked terrible. They looked terrible because of inclusion of air bubbles than when you hand manipulate. So the question is, do patients love Bioclear? And the answer is yes. Is the look of a Bioclear restoration different than a layered restoration? The answer is yes. What do most patients prefer? What do most patients prefer? They don't prefer layering. They prefer the Bioclear look. So to answer this question, which is a good question, let me show you a couple of black triangle cases, and then you can tell me if you think that it's aesthetically pleasing to the patient. So let's wait and look at a clinical case, because these dentiform cases, we don't know what these look like. These teeth are dead. Bioclear allows the native tooth to come through. So let's wait on that very important question about what is beautiful. The question is, what is beautiful to the patient's eyes? What is beautiful to the patient's eyes? Elimination of negative space. Shape, shape, shape. That's all that patients care about. They want this beautiful shape, healthy, smooth. It's the new sexy, right? The Bioclear is the new sexy when it comes to what patients love. Layering is an old conversation, and that's an interesting conversation from the past, and it's okay to have those, but we have a new conversation. That's about the beautiful shapes and the softness of a monolithic restoration that has beautiful optical characteristics on the surface. I'm going to show you specular highlights. Specular highlights are way more powerful than layering. Specular highlights is the new layering, because I'm going to show you when I do the finish how to create beautiful optical little things that make dentists happy. Patients don't care. So this is the new sexy, right? That replaces layering. We'll show you in the Rockstar polish. Go.
Okay, I believe
That's it? Okay.
Yeah.
We've got to hurry. So we're gonna go to the two-step Rockstar polish, then we've got to show you some cases because we're running out of time, and Pratik's got to show his cases. Okay. So the first thing that we're going to do is we're going to bring in the magic mix, and this comes in a little pate, and we're going to be using a disposable cup for this. And so what this does is it allows us to remove the deep scratches and also to round any of the areas that might feel sharp to the patient's tongue. So I'll get a bunch of this magic mix. And the good thing about magic mix is it's relatively inexpensive. A tub will last you for a year. I'm going to get some of this magic mix, and we're going to flange it over the tooth and marry together the Bioclear zone and the injection molding zone. You can flange this subgingivally to remove overhangs, like that. Pick up fresh magic mix. I'm running this really at a slow speed with a light pressure, and then we're going to run this over the lingual. This allows, because we're not doing bonding. This is the whole tooth. We've injection molded the whole tooth. So that's it. We're going to remove this. Suction. So what we want to see in this step is we want it to look like etched enamel. We want shallow scratches, which you're beginning to see some of the character that we're able to build that will create the specular highlights. And then we're going to go to the Rockstar Polish Cup. This is the second part of the Bioclear polishing system, and that is a diamond impregnated cup. We used to use the Jazz polisher, and now we're using the Rockstar polisher because it's a lot stronger and holds up better than the old Jazz. So I'm going to use the cup dry at first on its side to create some mamelon grooves. Now you can start to see the shine. And I'll go dry here for a minute. Go ahead and keep blowing air. You're going to want to have your dental assistant blowing air, and then use the specular highlights to guide your polishing. I can use the cup on its side. It's a lot more aggressive when it's dry, and it's a lot more aggressive when it's on its side. I can really flex it and create some mamelon grooves for beautiful specular highlights. And we would do the same on the lingual, but I won't show you that. And then we go to the phase 2 of step 2, and that is to go in wet. So go ahead and spray water, please. And you want your assistant to be about an inch away from the tooth so that you get a good spray pattern. You want to move the cup slowly. We're going to use 3 pounds of pressure. We actually use a gauge at the Learning Center to make sure that you're pushing with 3 pounds of pressure. And now the composite becomes very translucent, and the optical integrity of the composite has been maintained. So let's stop and take a look at this. So what patients really love are these specular highlights. So I'm not completely polished, but it's so beautiful, and then the natural nature of the tooth can come through. So what we're going to do now is we don't want to run out of time, so I've got to show you these cases because this is just a plastic tooth. It's not real. Let's look at some real cases, and then you can answer in your own mind, is this beautiful to the patient, right? Is it beautiful to patients? Because let me tell you what, patients are going crazy for Bioclear. They fly from all over the place. So why do patients love the Bioclear look so much? Let's take a look at some quick cases. Then we want to show Pratik's cases. So where do I go? Share screen? So let's take a look at these cases very quickly. I can't answer any questions because we've got to get done. We'll answer the questions at the end. Okay, so here we go. So here's a peg lateral case. This is from last week. Here we talked about delayed wedging. Everyone remember delayed wedging? We put the hip in. I did this yesterday, delayed wedging. Put in the hip of heated flowable, wedge it, release the matrices, injection mold. There's immediate post-op, 3-year post-op. Here's a 7-year post-op. Here's an 8-year-old post-op. Here's a 10-year post-op. Here's an 11-year post-op. So the question that everyone asks is, what about layering? Well, this lateral incisor looks a lot like her canine, doesn't it? And when I ask the patient, what do you like better? Do you like the eye tooth? Do you like your central incisor with a gray edge? Okay, gray edge. Or do you like your canine? What do you think the patient likes best? This is her Bioclear restoration. It's visually soft. It's smooth and beautiful. I matched her canine because that's what Bioclear looks like. What do you think the patient likes better, though? I asked the patient, this is your Bioclear tooth. It looks like the eye tooth. Which tooth do you like better? Do you like the central incisor with the gray edge, or do you like the canine with soft translucency? What do you think she said? What do you think the patient likes? Does she like her eye tooth better or her front tooth better? Her central incisor. What do you think?
Canine tooth.
What's that?
Canine.
Canine. It's beautiful. It's soft and natural. And we don't need to build gray edges. Patients don't want gray edges. So it's a new conversation. The new conversation is, what do patients like? They like this. Simple, strong, and beautiful. And 11 years later, it looks perfect. You don't see that with layering. But there's 2 people in all of India that can layer a restoration and have it look good 11 years later. The rest of us, it won't last. So once again, new conversation about monolithic, 2009, 2018. There you go. Okay. So if we're doing a normal class 3, we don't have to injection overmold the whole tooth. This is classic Bioclear. I think Jane and Abdulrahman, they use a lot of classic Bioclear. This is the HD. Once again, there's a, we're going to do these teeth together. That's my shield matrix here. We do use wedges if we have to have a contact. I'm going to fill the first tooth here. I can take that in 3 minutes and be done. And then I'll go ahead and remove the matrix. I'm going to do progressive wedging and go to the next wedge. I'm going to be doing the central incisor now. There's a couple of views. We etch to the edge of the matrix. We always etch to the edge of the matrix, and that's where our infinity edge goes. There's the lingual, and here's all done on the facial. Once the teeth are rehydrated, it's going to be smooth and beautiful. There's an old bonding right there. Can you see the margin on that traditional bonding? It doesn't work. It always leaks and stains. Injection overmolding is safe and simple and sparkly and sexy. It creates an ability to give us a nice patient-centered outcome. So here's a case done by one of our graduates of the Learning Center. Look at this kind of stuff. Amazing, right? I mean, why would you even think about putting crowns on that patient? So the Bioclear method, whether it's a little class 3 or it's a big case, it's powerful and simple, predictable. So let's take a look at negative space. Negative space tells us something wrong. The first thing that patients say about negative space is it makes me look what? What does negative space make the patient feel? I feel blank. What's the word they use? Number 1.
Old.
Old. Okay. No one wants to look old. Okay. Number 2, disease, neglect, poverty, lower intelligence. These are all the things that patients report to me why they want their black triangles treated. Genetic disorders like missing teeth, and then death. Death, really. Yeah. I had a patient who said, these things look like skeleton teeth. Skeleton teeth. I'll tell you what we're all afraid of. We're afraid of dying to a degree, right? I'm not that afraid of it. It's going to happen. It bothers me a little, right? People, they don't want to look dead. Black triangles make you look dead. Isn't that crazy? So the research shows that patients hate black triangles more than they hate crowded teeth or dark teeth. So people do bleaching, people do orthodontics, but to a patient, black triangles are more impactful. So Jane, are you with me?
Yes.
If you want to do black triangle treatments, you have to begin to talk about it. You begin to have to take photographs. You've got to put a brochure on your counter. It has to say black triangle treatment on your website using Bioclear and injection molding. Does your website say that?
Not till now.
You
No,
go
no,
tomorrow.
no,
Okay, I'm going to check you in a week. In a week, it better say that. Because here's the thing. I get an email from someone in India every week who says, who does Bioclear here in India, right? Why are you hiding yourself? Do you hate your patients?
No.
They're looking for you. You have to put it on your website. You have to say, I do the Bioclear method, okay? If you're doing the Bioclear method, right? You have to be using the Bioclear method to say that, because legally you can't say it if you're not using the matrix and the method, right? Patients are looking for this more than bleaching or black triangles, but we have to make a conversation. We have to start talking, okay? We need to be ready. You're not ready yet, okay? These are some of the many black triangles I treated. Some of these were on dentists. So there's the bonding, okay? Nobody wants that, okay? Don't say bonding on your website. Jane, your website needs to say Bioclear method, okay? Because that's what patients are looking for, not bonding, okay? They know better. There's the Bioclear retreatment, okay? That's injection overmolding. Patients love it, okay? Here's one of our graduates. This is his first case. He charges a crown fee for black triangles. So we charge about the same as a crown to do a black triangle. That's fair. It's a wonderful treatment. It's like a crown. Here's Dr. John Yoon. Beautiful. Follow the rules. Injection overmold the whole tooth, polish it back, okay? We'll skip ahead here. Here's an orthodontist that flew in to see me, hated her black triangles. There's her immediate post-op. Here's her 6 month post-op. There's her 6-year post-op. Patients love this method. It's strong and simple and beautiful. It's the kind of work you'd want in your own mouth. I've got a bunch of it, right? Like Jane, right?
Yeah.
So there it is. It holds up with the test of time. And like until they outlaw tea and cigarettes and red wine, things are going to stain. You have to have strong defense. You need defense with Bioclear. It's not offense, it's defense. How's it going to look 10 years from now? That's what patients care about. They don't care about today. They care about 6 years from now. And that's what it looks like radiographically. Now, it's not going to look like this if the matrix isn't seated completely. It's not going to look like this if you pick the wrong matrix. It's not going to look like this if you let the composite go out the other side, if you didn't use your shield matrix. So you have to follow the method. The recipe is simple. And people fight it. Even Abdul Rahman, when he went back, he didn't follow the Bioclear method 100%. I had Abdul Rahman, what are you doing? Everybody's stubborn. Everybody has to do it their own way, like your kids, right? Your kids have to like break the rules, and then they cut their finger, and then they learn that we have rules to keep us safe, and we have rules to keep us happy. We have rules to keep us safe, we have rules to keep us happy, but we break those rules because we don't believe them, right?
Yep.
I think people have to do that. That's okay, as long as they don't get hurt, right? So here's the black triangle instructions. Basically everything we showed you today comes in the black triangle kit. We use the gauge. That tells us pretty much which matrix to use, and then we'll use small on the small teeth and large on the large teeth. We're going to use disclosing solution. You have to use disclosing solution if you call it the Bioclear method. We're going to blast away, sand the contacts, seat the matrices. So once again, these two matrices are called the aquarium matrices, and these matrices are called the what matrices on the side? What did we call these two on the side?
Shepherd matrix.
Shield matrix. It keeps the, we used to call it shepherd, now we're calling it shield. We thought it was a better name. Sorry to make you crazy. So that's what this looks like. If you use a well-punched rubber dam, you can see the beautiful seal. If you don't use heated composite, what's going to happen when you injection mold? Overhangs, right? You have to heat it. You have to follow the recipe. That's a very tiny space. So we injection mold the first tooth, then we go to the next tooth, off we go. So I don't need a shield matrix here. Take it to 80% and go on. Simple, simple, rockstar polish. All right. We use the A102 on the other case. This is a case done by Dr. Charlie Regalado, wonderful guy. I think, I don't know if you Pratik, if you met, but Abdul Rahman has met Charlie. Wonderful, beautiful hand. So I hope someday some of you can come to the Learning Center of the United States and meet this guy. He's a wonderful person. He's a great teacher, very humble. I want to show you one of his cases. So Annie came in. She had gone to the periodontist and had periodontal surgery, and she ended up like this. Now, Jane, does this case make you nervous?
Does.
It used to make me nervous. It made Charlie nervous. Today, easy. Even with this dentin, we can bond to dentin when we shrink wrap it. Okay, we can bond to dentin. And so here she is, just devastated. She came in to his office crying. She was crying because negative space looks much worse than almost anything else. So we all need to be using the new lexicon. Pratik, we've got to talk about negative space, unfamiliar negative space, bad negative space, because that's the lexicon. So here are the lateral views. The patient had limited finances. She could only do 4 teeth. He didn't get to do more teeth. So because he only did 4 teeth, he didn't do as much veneering. He didn't bring the brightness of the tooth up very much. He couldn't add very much volume to this case. So this case, he only added a tiny bit on the facial. Here it is preoperatively. The periodontal disease has been taken care of. The teeth are stable. We don't do Bioclear on unhealthy teeth. We can do disease control, but with this, the patient needs to be strong and healthy. He's trying the matrices in. This is classic Bioclear. So I know like Abdul Rahman loves to use classic Bioclear. You can use these for black triangles, but you have to measure them. Here, there's not quite enough curvature. Here, there's too much curvature. You need to trim these matrices a little bit because those are the greens. Here's immediate post-op. And so if anybody asks, is this aesthetic? Let me ask you, is that aesthetic enough? Does it need to be any better than this? Could this case be better? And I think the answer is, it's good enough. You don't need to do anything more. Here's our 2-year follow-up, because if you layer, you're not going to see that kind of post-op 10 years later. It just won't look like that because there's bubbles, there's gaps, there's seams. Optically, it's not the same. Look at the beautiful, it's so translucent with the Bioclear method that the natural color of the tooth is able to come through. So there she is. Here's the preoperative x-rays. You ready for the post-operative x-rays? Here you go. Boom. Woo! So the periodontist says the teeth are less mobile, there's less food impaction, they're healthy, easier to keep clean. And of course, the most important thing is that we were able to change this lady's life. She's confident, they're beautiful. And so do patients love the Bioclear method? Yes, they do. Is it healthy? I think it's the healthiest way to reconstruct a tooth. It's a new conversation, isn't it? It's a brand new conversation, and it's not like anything that anybody's ever done before, right? It's disruptive, but it's fun. I think people just say it's fun, right? What happened to having fun? I mean, like Abdul Rahman was telling me these stories about his kids, right? What was the story about the tiger or something? He was telling me the story about his kids, right? Kids, they have fun, right? Let's have some fun for once. So let me see what people think about the aesthetics of Charlie's case. What does everyone think? Let's hear what the folks on Facebook Live have to say about the aesthetics here.
Tooth exposure is more post-operative.
What's that?
Tooth exposure more post-op.
I don't understand.
They like it.
The tooth exposure is more.
Oh, yes, yes. That I don't quite understand, but is that positive? Okay, yeah. Now, Jane, were you surprised that it looks this nice?
Yes.
Charlie was surprised, but he's not surprised anymore. He knows what it's going to look like. So one thing that you can do in the consultation some of the doctors in Italy, Pasquale Venuti, he'll take the matrix for the diagnostic, and he'll just take a matrix and put a little cold flowable composite in and cure it just so the patient can see what it's going to look like. And it's like a diagnostic wax up, but it's less expensive, less time consuming.
Even I'm doing so.
What's that?
Even I'm doing that.
Oh, perfect. Yeah. Because if you're worried that it's going to be a weird shape, we'll just put it on the tooth and see. Let the patient tell you. Do they like it? Yeah.
So one of the questions here is, what's your take on pink composites?
Well, pink composite is kind of an old conversation because the number one thing we need to get rid of is the unfamiliar negative space. And we can use pink or we can use white. And with injection molding, we don't ever layer. So every time I think about pink composite, I think, well, maybe I'll use it in this case, but we have such success with the Bioclear method that I've never needed to use pink. I've had a couple of patients actually ask me about using pink, and I said, well, I can, but then when we got done, they said, oh, it seems kind of experimental. We don't have enough experience. It's hard to know where to put the pink exactly, and then you're layering. So you could do pink, and I think that the level of difficulty with pink would be a 10 out of 10. If you want to do pink, it's a high risk thing with a potential high natural outcome, but it's risky. It's high risk because we don't know enough about using it. And once the once the negative space is gone, the patients technically don't care. So one thing that's new with Bioclear is these are patient-centered outcomes. If the patient's happy, I'm happy.
Perfect.
Yeah, good questions. These are good questions.
So I would want you to take this question because I told him that I'll take it live. The question is from Dr. Jacob. He says, I have been trying to find articles in peer-reviewed journals about the Bioclear Matrix system, but have not been able to. Is there a reason for that?
Yeah, there's a really good reason. Bioclear is new. It takes the scientific world about 25 years to do the research on a technique that is introduced by new movements. Okay, new movements happen because there's a need. Okay, there's a need for this. And so there are no studies showing that a GV black prep is good, right? There are no studies showing that GV black preps are good. We just inherited an old method. So 20 years from now, we'll see research on the Bioclear method. But there are studies that have been done. And so there are a few studies on the Bioclear method. One was done in Iowa showing that it was better and it had good contact. So there are a few studies. And if anyone's curious, you can email us and we'll give you the scientific research that's been done with 3M about C factor and some of these other things. But it takes a long time for the scientific world to catch up to actual techniques. You would think that you would do the science first and then do the method. We'll be dead, okay? Pratik, you'll be dead, okay? You'll be dead and stinky, okay? By the time there's enough research for the people that want to see the research on the Bioclear method, because you need 10-year outcomes, okay? I'm showing you.
COVID.
What's that?
Like we're waiting for the COVID, the
Right.
corona vaccine.
Yeah. That's good. Okay, we've got to get going. Pratik, can you show us some of your cases? Can we go to a stop share? And Pratik, you had some cases you wanted to share, yeah?
Sure. Tell me when I can start my screen share.
Okay. So you go to hit share screen, go to the bottom, hit share screen.
Yes. Can I start now?
Please.
Okay, so am I visible? Am I online?
Yes.
Okay, perfect.
Pratik?
So it was exactly 2 years ago, David, when I was there with you. Exactly on this day, I was taking a flight there to the Bioclear Learning Center, and about 2 years from then, showing a few cases, and these I have made mistakes while going on with these cases. So let's see if I can talk you through them. The first case here is a post-ortho case where the patient comes in and he has a partial relapse. Now, the part is the patient is going back to study out of India and he will not be back for at least 2 to 3 years. So I had to do it right then in that appointment. Like you always say, patient wants it right now. So that's the pre-op condition of the patient, where you have spaces, a partial relapse, patient never wore his retainers. Again, as you can see, always questionable with the maintenance. Now in here, if you can see in the previous slide, the space is pretty less for the diastema matrices to fit in. I would ideally need at least 1 millimeter of hip. But in this case, we decided to go with the anterior matrices. The A102 is one of my favorite matrices for these cases. And you will see a lot of them being used in the next cases also. So like in one of the cases that were shown where you just have a class 3 and you could partially overmold, we decided not to veneer this tooth. So that was the overmolding done. And that's the aesthetics post-op. Now, one part that I would like to answer here is I've seen a lot of questions and I did not take them up, saying, do I have the translucency? Do I have the opacity? Do I have the shape that gets matched when I do a monolithic injection molded composite restoration? I believe this answers it all. You can see the translucency, you can see the opacity, and the patient was pretty delighted at the end, as you can see in the smile. So for the patient, it didn't matter whether I was matching his translucency, whether I was matching his shades. For him, he wanted something that would last. And in the bargain, he got something which was almost aesthetic. In the second case that is to be shown, I would like to show a diastema closure and use the Bioclear gauge. So this was one of my first cases with the Bioclear gauge, and a pretty tricky one at that, because the patient never agreed to go to. They did not have the finances to go beyond the lateral. So I was ending up doing only 4 teeth. So you always take the Bioclear gauge, and the Bioclear gauge shows you the proportions. So you can always measure the width that you want. At least that's how I use it. I measured the width that I want, and then I cut back the height. Finally, I'll show that in one of the cases. So these are again anterior matrices. I could have used the diastema closure matrices here, the DC matrices, but like I said, I love my anterior matrices. The A101s on the mesial and the A102s on the distal. Injection molding both the centrals, then moving on to the laterals. And that's the immediate post-op. So this was just before the COVID arrived. So this must be about 3 months old, and the patient will come back for his final finishing. That a little tweaks that I have to do, but that's the post-op. I've maintained the width, and according to the width, I've also maintained the height that I was expecting. That's the comparison between the pre-op of the patient and the post-operative view. Now, another common question that is generally asked to me is that, can you do a class 4 build-up using monolithic composite? Because a class 4, according to people, needs different shades, different opacities, different translucencies. So let's see if I can satisfy a few of them. So this is how the patient walks in with a class 4 uncomplicated Ellis class 2 fracture. Both the teeth are vital. That's the isolation part. Like always, you check for biofilm, because I will be grabbing as much enamel as I can. You remove the biofilm. And at this point, we are ready to injection mold. Let's try my matrices in now. I could have used, in this, I've used all A102s. I could have used the A101s on the mesial, but then that's my injection over molded. That's the gross finish. Now, like I said, I have first used the Bioclear gauge to gauge the width of these teeth. So the width is about 8.5 according to the gauge, and the height, as you can see on the top, should be about 10. So this allows me now to measure the height. So I take a caliper, I measure the height. Since the width was 8.5, the height I would technically want would be 10.5 versus 10. So that totally depends on how the patient's lip line goes. You measure that height, mark it on those teeth, and now back to the 3-step rockstar polish. So you first take your discs, bring it down, then the final glass polish. So how do you like that, sir? With regards to the translucency, with regards to opacity, everything. I believe that's a monolithic composite restoration with all possible features. That looks good.
Oh, I like it. But now the thing is, it doesn't matter what I think. What did the patient say?
The patient just loved it. In fact, this patient is my sister-in-law, so I'll keep meeting her again and again. Let's look at the class 3 case now. Single case of re-restoration or failed restoration. Now that is patchwork for you. That is bonding, traditional bonding. It looks like that. And the patient says these restorations were done 6 months back. Trust me, people in India, I don't know, it's in our food, it's the colorants that we use. These yellow stains are very common. One of the reasons that has been given to me by a very high level 3M guy is what he says is the use of turmeric. So turmeric, which is a common additive in all our foods, it leads to these yellow colors. So that's more or less my prep. I decided to veneer those teeth. Those little areas which look carious were taken off by a hand explorer. first that we do is do something like a root overlay, where flowable composite is put on the gingival surface. This also helps in holding the matrices in place. Injection.
Pratik?
Yeah.
So this is the benefit of us all getting together and having a community. I want you to back up 3 slides, please. By the way, these are beautiful. I'm really proud of all your work. Back up, stop right there. Okay, go to the other slide. You just went past.
The preparation slide.
The prep, yeah, the prep slide. Let me see the prep slide. Yep. Show me the other one that was upside down. Right there, stop, okay? So what we want to change is, because this, and it's a beautiful case and it worked out great. But what we want to change from is abrupt transitions from thick to thin. So you can see that Pratik has a very carefully prepared gingival bevel that's more like a chamfer. What we want to do next time is to do a radius bevel down there like you've done, but then have it end with a feather edge, and then do additive dentistry and go past the margin of your radius bevel. So if you could imagine, what you do here is, instead of having a sharp, abrupt end of your bevel, Pratik, take that radius bevel, move it 1 millimeter more away from the gum line, so that your radius bevel is 2 millimeters away from the gums. And then you're going to do additive dentistry, go past the bevel onto clean blasted enamel, so that you have an even better infinity edge. So this is kind of your porcelain brain telling you to put a veneer margin there. We can always do a little bit of additive dentistry. Now, does that make sense?
Yes, absolutely.
Yeah. We're all learning, right? Every one of us. And I did a case yesterday. I'm still learning. Okay. I'm still improving. So go ahead, finish the case.
Okay, so this was the root overlay that we did, and the matrices were in place, the injection over molding in place, and that's after cutback. So I believe you have the translucency, the opacity, and the specular highlights, as we like to call with the Bioclear method, all in place. Patient is happy, teeth are all smooth when she runs her tongue, and these will not catch plaque. That's what is more important for us.
So Pratik, do you have any 2 or 3 year post-ops yet? Post-operative?
Yes, I do. Yes, I do. I will share them. I will share them at the end next time. With all my post-op. Perfect, because that's the most important thing, because it's the resistance to turmeric and these other things that matter to patients. You know, a 1 minute post-operative is only important to doctors.
You have 3 year post-op sitting here.
What's that?
My 3 year post-op is in panelist.
Yeah. So those are the important ones to show, because that's what patients care about. Okay, good.
So that's the immediate post-op for the patient, and a strong incisal edge always. That's what matters.
That's what matters. Yep.
So let's look at a final case with dark triangles, and I was trying to show all possible variety of cases that you can do with these Bioclear matrices. And in this case, if you can see, on the second quadrant, I already have crowns that have been done. The patient comes in, and she was referred to me by a periodontist after her scaling and her planing procedures were done. And she did not want to use a Christmas tree brush as good as that. He said no to Merry Christmas. So she wanted me to make them self-cleansing. So we started off there. The Bioclear matrices in place, my aquarium in place, along with my shield matrix. Now I still call them the shepherd matrices. So my shield matrix in place, injection over molded 1, and now that acts as my shield for the next tooth. So you go ahead and injection over mold the next, and finally the canine. So that is the post-op for the patient, and that's how the patient goes back. Does the shade look good? The patient just loved it. She couldn't identify whether it was yellow or white. She just loved the way her teeth were. She loved the fact that she did not want to use that Christmas tree brush again. So these were my cases that I wanted to show, so that the audience that's listening understands that for a dentist like me, who I always call myself with two left hands. I do not have a right hand. So I'm a two left-handed dentist. And if I can get results like that, people who are more talented will get better results. Thank you. Thank you for having me on this panel. And thank you, Dr. Clark, for taking pains to show this.
Oh, I love looking at these cases. These cases are, every one of these Bioclear cases it's a beautiful story. There's always a beautiful patient story that comes with these Bioclear cases that I think is so very enjoyable, because it's really patients that are driving the Bioclear method. And that's going to be the challenge, and I'm challenging everyone in India, is that you need to get a hold of the branding of the Bioclear method and use it for having patients have a value for this, and beginning to, make it an important part of your practice. So that is wonderful. We are just about out of time. I wanted to show something that that 3M has shown, that build a video. And so if you have a patient who's interested in Bioclear or black triangles, I want you to refer them to YouTube for this video. So I want to go back to share screen. I want to show this last video. So I need you to get out of share screen.
I've got my share screen.
Good, thank you. Okay, so let's show this real quick. Oh, okay, it's showing right. So, what's interesting is the, can we just get everybody's faces up big and get off of the, just do a stop share here. So what's interesting is that the, like the doctor said, if I look for research on the Bioclear method, where is all the research? What's really interesting is the world's biggest composite company, has selected the Bioclear method as one of the best ways to use their composite. Now, they've done a lot of research internally at 3M, and we can share some of the research that's been published about the Bioclear method, but the Bioclear method is a movement. It is a movement that is very different than what has been done in the past. And if you're going to use the Bioclear method, you need to describe it in a way that makes sense to patients. And the word that the patients invented the word Bioclear method. Now this is Abdul Rahman. This is a funny story. A patient sent me an email 10, 15 years ago when we just invented Bioclear, the Matrix. I didn't even call it the Bioclear method. And a patient asked me, Dr. Clark, I'm looking, and I'm very interested in the Bioclear method. And I thought, I like the sound of that. So that was the day that the Bioclear method was born. It was born when a patient said, I want the Bioclear method, because it was a method. And I was so early on, I was just a scientist, just a normal dentist trying to do better dentistry. And one day all of a sudden one day we had a beautiful method that was very different than anything else. And so what I want everyone to understand is that you need to call it the Bioclear method, because that allows you to move forward with new conversations for both teaching and new conversations with patients, because the patients want this. They don't want to use the Christmas tree brush anymore. They don't want bonding. They don't want stain. They understand that this is going to be a different outcome for them. So that's the mission statement for today. Do we have any quick questions that we want to answer? Ali, if Dr. Abdul Rahman, if you wanted to have any last words before we sign off for today. The next 2 weeks, we'll be talking about posterior composites.
Okay, I just want to comment about Charlie's case, because when you have a case like Charlie's case, the patient has a very healthy, stable periodontium, and there's no motility, and you have no option but doing a Bioclear. If the patient even can afford the implants, and you think that you can ask him to pull out these teeth, you cannot stabilize the tissue, the level of the tissue. You don't know if it will be even at the same level of that or not. So you have a very stable periodontium, you have a healthy tooth structure, and you just make the patient smile more better, and you made the tooth live longer, because the possibility of caries because of the space that it was before will be less after doing Bioclear. So in some cases there is no option but Bioclear. In other cases we can talk. We can, like, what do you do better? What do you like better? So it's a type of treatment that you should, I can say you must have in your office, because you will have this kind of cases that the patient will tell you, I cannot pull out the teeth, and I just need to have a teeth in my mouth that I don't have to clean it with the, like David says, Christmas tree brush.
Merry Christmas.
Just it.
Okay,
I
so
want to
one
comment
final question that I would want you to take here, Dr. Clark, is, do you only recommend 3M composites for the Bioclear method?
Now, we've used, that's a very good question. So there's a simplicity to the Bioclear method. And when I was treating this patient yesterday, she had an incredibly complex case. I don't want to worry.
I don't want to interrupt you, David. I have to go now. They calling me outside in the office. So it was a pleasure to meet you guys. Yeah, I have to go. They're just calling me. There's something I have to do outside. Okay.
All right.
Okay. So I have to go. Bye-bye.
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 So to answer the question, thank you, Ali. To answer the question, we use 3M because the body shade, when you take a look at Pratik's cases or Charlie's case or my case, once you put it on a human tooth, the body shade with the Bioclear method, all the composites with Bioclear become more translucent. So with Bioclear, the composite becomes more translucent and the value goes down. Translucency goes up, the value goes down. The tooth shows through with some opacification, which is good. So it's a magical opacity. So you don't have to use 3M composites, but 3M composites have the most studies showing safety to heat. There are 2 composites that we've seen that you cannot heat. And there are a couple of composites that are not so great to heat. We know that 3M has the most studies validating the heating. The other reason that we use the Filtek Supreme Ultra is that the flowable composite that's so important to us has the exact same optical characteristics as the paste. And we have to have a little bit of flowable, like light body, heavy body. So the flowable needs to have the same optical characteristics, and the flowable has to be strong enough that if wherever it is, which is a small percentage, it has to be strong. It has to be aesthetic. It has to have pretty good shine retention. And so another reason we use the Filtech Supreme Ultra is that it has very good shine retention. So it has those specular highlights. Some of the composites don't keep their shine, and that's not going to look good 3 years later. So it needs to keep the shine. So that's another reason for Filtech. And then the last thing, or another thing, is that the Filtech is a very creamy composite. It's not hard. There are a lot of composites that are very hard for layering and hand packing. That's an old style. That's not for injection molding. So you can take a composite. I won't mention some of the brands, but you know what they are. They're pretty hard. And they meant to squeeze them out and put them in by hand. If you try and inject those composites, you'll get an overhang, even if you heat them. So what you want to use is Filtech Supreme Ultra, which we like for the anteriors. And I'm not sure what they have in India, but something like that. But we want the body shade. I don't want enamel. Yeah, I don't want enamel. I don't want translucent. I don't want dentin. We just use the body shade, and that allows us to focus on the most important thing, which takes us back to the lady that we started with. She didn't like what? She didn't like the shape. Bioclear allows an amazing shape. Focus on shapes first. The color will take care of itself, right?
Yeah.
It's like with your children, okay? Show them a good example. Show them that you care. Show them that you're a good person. Show them that you're a hard worker and honest. They'll take care of themselves, okay? If you don't show your children a good example, then you're going to be trying to fix a lot of problems, right? It's the same thing. You have to have a beautiful shape. And once the beautiful shape is done, these things will take care of themselves for color. We're having the wrong conversation with color, right? We should be having shape first, longevity first, stain resistance first. The color will take care of itself.
Perfect. So one other question that's here is, how do you compare between warming a syringe versus warming a compule?
Oh,
yeah.
Syringes versus a compule.
Yes.
Yeah, we need to move to compules. The syringes are just, I know everybody uses syringes, right? And we just need to move on. You're going to be suffering, right? It's like if you're going to go for a walk and you have a little rock in your shoe. You ever had that happen? You're walking and there's a rock in your shoe or your sandal, right? Especially in India, guys wear a lot of sandals, man. You must get rocks in your sandals all the time, right? You just get rid of the rock. So it will get in the way. And once you start charging a more appropriate fee for Bioclear, the cost for the compules is actually not that much more. And you'll just have a better result. And so that's a good question though, because a lot of India and a lot of the world still use the syringes, but it's, by the time you take the syringe and twist it out and put it on an instrument, it's cold.
Yes.
It's cold. It's cold in about 10 seconds, 15 seconds. That's it. So anyway, good question.
One final question can we take?
Yes.
After injecting warm composite, is there a time limit for curing after placing the composite on site?
That's a good question. That's a good question. I can tell that the doctor is watching and listening. Okay.
He's been a participant in my previous courses.
Perfect. Okay. All right. So what we understand is composite has very low thermal conductivity, but it also has low specific heat. So the composite is like popcorn. You guys eat popcorn, right?
Yeah.
Okay. Popcorn doesn't stay hot very long. Okay. Neither does composite. And popcorn doesn't burn your mouth because it has low specific heat and low thermal conductivity. So composite doesn't hurt the tooth. But on the other hand, when you put hot composite on a tooth, it's going to lose its heat in a matter of a few seconds. But the great thing is, once you've injection molded the composite and it's had thixotropic flow and it's been able to engage the tooth, now we don't care if it's hot or cold. And so don't worry about hurrying to cure it while it's still hot. It doesn't matter. You can take as long as you want. Once you've injection molded, the matrices are in place, relax. Okay. You can even do little adjustments to your incisal edges before you injection mold. So the heat was only important during injection molding. As soon as your injection molded, relax. You don't need to hurry. Everything is going according to plan. But that's a question that people naturally ask, and I'm glad that they asked that. So I hope I answered that. Does that make sense?
Yes.
Good questions. Good questions. It's late there. Everyone's still pretty awake.
It's you online, by the way. So people will be awake. Okay, so we shall call this a day for today. Everyone is waiting for the posterior next time.
So before now, part of me coming on here, as you can see, I'm getting some gray hair in my beard. I need for the next generation to stand on my shoulders, do better than me, and teach the world how to do injection molding. So that's why I wanted Pratik and Jane. So Jane, if you wanted to share anything to the doctors about your journey with Bioclear before we give it a wrap today, and then we'll let Pratik do the final goodbye.
Perfect.
My Bioclear journey started with, I guess, with Pratik only. When I had my first restoration mount, which was a class 2 in 2.6. Was back in 2016, I guess. 16 or 17. Yeah. That's when it started actually, and I had done my master's in prosthetics. When I learned Bioclear, when Pratik came to your center, he went ahead with a thorough training with me. And he came back. I guess I was in his first course, attending with him, coordinating with him, arranging for him with him. And that's when I got to learn Bioclear as such. And in those times, I was doing a lot of inlays and onlays for posterior, a lot of indirect veneers. I'm a prosto guy. I used to believe more in indirect. Change. That's when the transition came. That's when I had an option for myself and for my patients whether I can go with done directly inside the mouth. And then my inlays and onlays are invisible now. I don't do anymore. Moreover,
Jane, your audio is cutting out. So we're going to say goodbye to Jane. We got most of your story.
Yeah.
Work on your microphone for next week. Okay. All right. Okay, Pratik, go ahead and if you can tell everybody what we're doing next week and say goodbye to everybody.
So we start off with posteriors next week, and we will be taking the class 1 and class 2 next week. So I believe everyone is excited about the posterior because that's the hottest selling piece of matrices in India right now. Yes. So everyone is waiting for the step-by-step as to how they want to go about doing the posteriors. On behalf of the World Dental Association and my aesthetics group, I would love to thank you for being with us. I would thank everyone for staying up late, although it's not late, but for staying up with us for the past two hours and listening to us. Thank you, everyone. Have a good night. So and you, Dr. Clark, please stay safe.
All right. Thank you. Goodbye, everybody.
Take care, Dr. Clark. Bye-bye.